Today I'll be discussing multiple sclerosis, a complex neurological disorder. I'll walk you through its pathology, clinical signs, and how it affects movement and current treatments, including the role of rehabilitation and exercise. Let's begin with a broad overview of multiple sclerosis pathology. MS is a chronic immune-mediated disorder that affects the central nervous system. It is marked by demyelination, axonal damage, and neurodegradation. On the left side of this image, you can see a healthy neuron with its myelin sheath intact. This sheath enables fast, efficient signal transmission along the nerve. On the right, we see a neuron affected by MS. The myelin has been damaged by inflammatory immune activity, exposing the axon. This not only disrupts cellulatory conduction, but also makes the axon more vulnerable to degradation. Over time, these changes impair signal transmission and lead to the neurological symptoms associated with MS. While the precise cause of MS remains unclear, genetic susceptibility and environmental triggers such as infections or vitamin D deficiency may initiate immune activation in the periphery. Once activated, autoreactive T and B cells begin to target central nervous system antigens. These immune cells accumulate at the blood-brain barrier, where early dysfunction allows them to enter the brain and spinal cord. This breakdown in the neurovascular unit, due to disrupted endothelial signaling and tight junction degradation, enables entry of pathogenic lymphocytes into the central nervous system. Once inside, these immune cells orchestrate an inflammatory response. Activated microglial macrophages and CD8 positive T cells attack myelin sheaths and axons, leading to the formation of demyelinated plaques. This neuroinflammation and structural damage ultimately manifests as the diverse symptoms seen in MS. This comparison of MRI images helps highlight the regional damage caused by MS. On the right, a healthy brain shows normal white matter without lesions. On the left, the brain with MS shows multiple hyperintense plaques on T2-weighted imaging, especially around the ventricles and corpus callosum, classic locations for demyelinating lesions. These lesions represent areas of focal inflammation, myelin breakdown, and axonal damage. While white matter is most commonly affected, MS also targets grey matter, especially in later stages. This can lead to widespread cortical atrophy and cognitive impairment. The pattern, location, and evolution of these lesions influence the clinical presentation. For example, brainstem lesions may cause diplopia or vertigo, while spinal cord involvement may result in spasticity and sensory loss. Multiple sclerosis symptoms vary by lesion site, but commonly include weakness, spasticity, fatigue, sensory changes, pain, visual loss, and bladder or bowel dysfunction. Motor signs often involve spastic paraphoresis with increased tone, hyperreflexia, and a Babinski sign. Weakness may stem from impaired conduction and disuse. Cerebellar or brainstem lesions cause tremor, ataxia, and dysmetria, affecting coordination and gait. Sensory changes, often early, include numbness, tingling, and altered sensation. Dysphagia, used in later stages, reflects corticobulbar or cranial nerve involvement. Fatigue is a core feature driven by impaired neural conduction and systemic inflammation, not just physical effort. Even early in the disease, patients with MS often show poor balance and altered gait patterns. This includes increased postural sway, difficulty shifting weight, and delayed reactions to balance disturbances. These deficits reflect impaired integration of visual, vestibular, and proprioceptive inputs. Fatigue, tremor, and spastic paraphoresis further impair movement and contribute to falls risk. Neuroplasticity, the brain's ability to adapt structurally and functionally, is crucial for recovery and slowing progression in multiple sclerosis. As shown in the figure, structural plasticity involves physical changes like axonal sprouting, while functional plasticity refers to altered synaptic strength. Despite demyelination, the brain compensates through network reorganization and gene reactivation. Plasticity declines with age and disease duration, but physical and cognitive training can enhance it, promoting remyelination and improving function. Neurorehabilitation is therefore vital in disease management. The medical management of multiple sclerosis focuses on three pillars: controlling acute relapses, slowing disease progression, and managing symptoms. Anti-inflammatory medications such as corticosteroids remain first line for managing acute exacerbations, with additional therapies like immune-based treatments or blood filtration techniques used in cases that do not respond. Disease-modifying therapies reduce the frequency of relapses and the risk of long-term progression. These include both moderate efficiency and high efficiency agents selected based on disease activity and individual patient factors. Importantly, rehabilitation is often underused or overdelayed, despite strong evidence supporting early intervention to preserve neural function and maintain independence. Rehabilitation in multiple sclerosis goes beyond functional support. It influences the disease environment. It reduces inflammation, enhances neuroplasticity, and increases neurotrophic factors like brain-derived neurotrophic factor and insulin-like growth factor 1, supporting neural repair. Exercise plays a crucial role. Tailored aerobic and resistance training improves cardiovascular fitness, strength, balance, and mobility. It also reduces fatigue, improves mood, and is linked to fewer lesions and slower brain atrophy on imaging. Starting rehabilitation early and maintaining it consistently delivers the best outcomes.